Welcome to TCN Talks and Anatomy of Leadership. We continue the conversation in part 2 of Private Equity, AI, and the Future of End-of-Life Care. And now, here's Chris Comeaux and Cordt Kassner.
Well, as we go into this next segment, I'm just going to cover my final ones very quickly and hand it to you. So kudos, because hopefully some of my for-profit friends will, when they call me to complain about some of the things in part 1, they'll maybe give me kudos in this one. But it was a hospice news. The VITAS CEO, new CEO, Joel Worley, 4 core values of hospice care. And Cordt, I think that was a high clicked on article. And, I think probably, I'm not dissing VITAS, but usually core values and VITAS are not the first thing that people think of. It was a great article, and the values were really well stated, and love that he actually put that out there. I think that bodes well for VITAS's future as long as those aren't words on a piece of paper. But it felt heartfelt, actually. It felt very profound. And any good organization calling people back to the foundation and the mission is a good thing. Last few things.
Just jump in real quick there. I would just slightly push back on you that when I think of VITAS, I do think of core values. And this did not surprise me a bit. I thought this was a well-stated article and well-received. It was one of the higher clicked-on articles that we've had. So kudos to them for what they're doing.
Good pushback. And then this was a healthcare's article. Don Berwick, one of my favorites, talking about From Laggard to Leader, why healthcare in the United States is failing and how to fix it. So here's just one quick excerpt. To achieve these goals, we recommend these changes to ensure coverage for all, which actually was one of our podcasts last year, which was the, I can't believe I'm spacing on the guy's name, but it was the prescription. He went and studied all the healthcare systems. T.R. Reid. He went researched all the healthcare systems all over the world. So coverage for all, invest in primary care and social determinants of health, create financing to incentivize population health, improve transparency, which was what we talked about a couple moments, price transparency, and accountability. And so major systemic transformation of the U.S. healthcare system is not just required, it's a moral and economic imperative. And one of my predictions is it's going to come to a head this year economically, and the red lights on the dashboard of why the current system is not working. Whether we do something or not is still the crapshoot. And when you and I did the show in January, we weren't in a war in the Middle East, which we now are. And there's, in some of the hiring data, healthcare was really still kind of fueling the economy. Now there's some mixed signals there, amid some broader economic challenges brought on by the war. So it really is a crapshoot about the signs are going to come to a head. Do we do something about it? You got the midterm. So I'm just calling that out. I don't know how it's going to play out. But if we don't fix healthcare, we go bankrupt in the Medicare system by 2033. So it's going to be the only opportunity. It's kind of like road is out up ahead, major sign. You just keep going, or do you do something about it? That's kind of my prediction of where we're headed this year. Not saying the road is out this year, but it's out at some point in time in the very near future if we don't fix up.
The only thing I chime in with this one is I have often said, if Joan Tino writes it, I'm going to read it. And Joan's coming up on a future podcast, which I'm really excited about. The only challenge I'd throw out there for you, Chris, is I say the same about Berwick. If Don Berwick writes it, I read it.
Yep.
Let's get him on the podcast.
Oh, that's going on the to-do list, man. That is going on the to-do list. And we actually have a team member who knows him well. So thank you for that recommendation. All right, last one, and I'm handing it to you. How private equity is ruining hospice care in the United States. This got me thinking. So I am obviously very pro nonprofit. Got me thinking, instead of just dissing on private equity, we did a past show. Laura Katz-Olsen wrote a book called Ethically Challenged. But if you step back, what is the role of private equity? And here's a cool analogy. So private equity, really the role is to buy companies, to try to improve them and sell them later for more money. There is a contemplated exit to extract value. Nonprofits, there is no contemplated exit. You have a compact with the community to care for people. At end of life, I think that's a core differentiator. And I think that in your report card of the top 50, I think it was slightly down the number of the top. I think of the top 10, 5 were kind of PE owned in the past. I think it was 6. So one kind of dropped. So hopefully that's maybe a good trend. But I think private equity coming into the hospice space, because They need to crank out outcomes. Now, so then the hypothesis is hospice is a space where you could generate large outsized returns, because that's what PE is looking. It's not looking for a normal return. It's looking for outsized return. Here's an analogy that I found. Imagine buying a house. You renovate it, you improve it, you increase the value, you sell it. The bad version of that is you take out a huge loan, cut corners on repairs, try to flip it quickly, even if the house isn't better. Unfortunately, in hospice, most of the examples, PE back, it's more of the latter. It's not part of the former. Now, whether that changes going forward or not, we'll see, but I'm just calling it out. To me, the data really supports more of the latter, and I've got lots of anecdotal examples. We've interviewed people, work for private equity, maybe trying to recruit them in some of the hospices we work with. I've got a perfect example. The guy's like, and we were cranking like 30% margins. They called and said, we want 12% more. 70% of those costs are staffing costs. Where is it going to come from? People by the bedside, getting back to your example in your family court. So I thought this was a good article. I don't think private equity has a good space in healthcare because healthcare is perverse. The more you do good for people, you should make more margin. And that is the core problem. Private equity needs to go at other places to create outsized return.
And I think what you're describing is what a lot of people are very concerned about with the entrance of private equity into not just healthcare, but hospice in particular. My pushback is, and you said it in your comments, the evidence you have is anecdotal. And the reason I'm pushing on that button is because I'm involved in a couple of research studies that are trying to answer the question based on data. Does private equity ownership make a difference? And we're actually seeing, based on quality data, it does not, that it is not based on private equity or for-profit, nonprofit. There are other factors at play that are driving some of that. There are egregious examples, no doubt about it. But is that characteristic of the entire field? And right now, I would say we don't know. And so we're looking, and I would encourage listeners to take all of those questions and add more questions to the pot, and let's go explore before we throw any provider group under the bus. Let's actually figure it out first. And so the good news is that those projects are underway. Like, we're looking. That ties into that hospice news article on the 50 largest chains. Well, we need to identify who the chains are so that we can look at outcome measures. And that's what we're doing now.
Or you take it over.
So when I took a look at the articles over the last 3 months, there were a few that really popped out for me. And Chris, great articles that you were reviewing in the first half of the show. I'm using Ira's framework in particular for identifying articles. And so Ira starts off with zero tolerance for waste, fraud, and abuse. And over this month and characteristic of the last 3 months, we've covered about 15 regulatory and enforcement stories a month, underscoring how fraud continues to erode public trust and threaten the hospice benefits' long-term viability. So we start off with that side of the coin, that we need to eliminate that. One of the stories that had almost 4,000 clicks on it was Oregon's legislature passed the Protecting the Dying Act, Senate Bill 1575, which requires background checks for hospice owners, sets minimum qualifications for administrators and medical directors, and bars individuals with histories of healthcare fraud and abuse from owning or operating a hospice in the state. Importantly, it also imposes a temporary pause on issuing any new hospice licenses until the Oregon Health Authority, their Department of Health, can update its rules with these enhanced protections. This bipartisan effort, led by Senator Deb Patterson and supported by leaders such as Barb Hansen and the Oregon Hospice and Palliative Care Association, sends a very clear message. Ethical, patient-centered providers are welcome. Bad actors are not. What I found really interesting about this was I know that there are multiple states, there are many states considering these kinds of protections to, I mean, very specifically, so that what happened in California doesn't happen in their state. I hope I hope all of our listeners' states are engaging in similar work. Know that someone, Oregon, has paved the way.
Man, for our good friend Ara Bayak, I was thinking about this the other day, and I hope you send this podcast to him. I'm a huge history buff. This is our 250th anniversary this year as a country. Many people call the soul of the revolution was Samuel Adams. He's not just a beer guy. Samuel Adams was the spirit behind the revolution, and many people called him a firebrand. That's our Dr. Bayak. Getting all over, he's gotten pot shots about the framework. Now the term collegiality ends a criminality is resulting in bills like, high five, Dr. Bayak. Whatever negative feedback you've gotten, kudos to you. Being the spirit of this revolution of making sure end-of-life care thrives into the future, the whole serious illness movement, I just want to give you a high five. I think because you've given us a good term, collegiality should end the criminality. There should be bills like this in every 50 states. I mean, the most vulnerable people of our population, and oh, by the way, you've heard me say before, Arnold Toynbee, who's studied every civilization in the history of man, the number one indicator if they continue as a civilization is what do they do for the old and infirm who couldn't do for themselves. This is a no-brainer. Right and left should come together for bills like this.
Absolutely. And on a personal note, Ira and I co-presented together. He invited me to join him in a workshop at AAHPM a couple of weeks ago. One of the highlights of my career. I mean, he's such an amazing man. It was such an honor to share the stage with him and even, continue learning from him as we're sitting next to each other presenting this paper. So as we get into his 4 calls to action, building on the momentum of integrity, these aren't abstract ideals. They're practical levers for distinguishing good care from truly excellent care, fostering transparency, rewarding quality, and reclaiming our authentic brand. So I picked one article in each of these buckets to discuss today. Under clinical and programmatic standards, how do we move beyond good enough to consistently excellent compassionate care? One of our most read stories this month, 13,000 reads. I think it's the second most read story we've run in the newsletter ever, was MedPAC's March 2026 report to Congress. This influential annual summary pulls no punches. Key highlights, for me anyway, included for fiscal year 2027, MedPAC recommends eliminating the planned update to the 2026 Medicare-based payment rate. That usually takes everybody's breath away. I encourage you to look back and see how often MedPAC has recommended this and how often Congress has actually done it. They have recommended it regularly, and that rarely happens. But let's continue with that. While it may feel controversial for nonprofit hospices, which in their report make up 16% of providers today and averaged a negative 1.3% margin, but this reflects the broader fiscal realities. For-profit hospices, now making up 82% of the sector, averaged a robust 13.7% margin. And MedPAC is long flagged. Margins above 10% is raising fiduciary concerns in a publicly funded program. In the second point that I'd highlight here, in 2024, more than 1.8 million Medicare beneficiaries, including over half of all decedents, received hospice services from roughly 6,700 providers, with total Medicare expenditures reaching $28.3 billion. So we're almost at we are at 30 billion when you include non-Medicare expenditures. The share of decedents using hospice has hit a new high at 52.9% in 2024, up from 51.7% the prior year. I consistently beat the drum around hospice utilization, and this is the highest hospice utilization we've had on record. So that's exciting. Some implications. Payment policy must balance access, quality, and stewardship. This is all we were talking about in the articles that you were reviewing, Chris. this balance between money and services provided. Some hospices have unique challenges, like rural providers and those specializing with pediatrics or dementia. And those deserved nuanced considerations in reform. One hospice is not the same as the next hospice. And we've got to, in my opinion, look out for our rural providers, look out for our hospices doing really unique work. This report invites us to reflect. Are our clinical standards rigorous enough to justify public investment, regardless of ownership model?
Well, I'm just going to point out what I think is obvious. 13.7% margin in the for-profits, negative 1.3%. Not reflective of confidence. It's reflective of where we put our dollar. Now, I'm not going to defend every nonprofit. I get to work with a subset. I would love the opportunity to work with all of them one day. We are helping these programs become high performance, and they're putting care by the bedside. I love your call out earlier when you were vulnerable in part 1 about your personal experience. Maybe we've been the victim of good is good enough. Good to great was all about has good become the enemy of great. I'm all about let's become great. This data shows that there's a difference in the model. Just maybe the interesting thing for you to follow up on, Court, look at who provides the 4 levels of care. Now, crisis care, continuous care is very difficult. At least look at those other 3, inpatient, respite, and routine home care. You get a lot of homogeneity in those for-profits, and you see some very long length of stay because they target then the nursing homes, get more non-cancer diagnosis, etc., which produces great margins. So they even cherry pick some in the patients. And that's some of the, again, anecdotal. I don't go all over the country. We do work in at least 14 states throughout the country. That's what we see, and that's what produces the difference in the margin. How they target the population, homogeneity, there's routine home care, mostly in nursing homes and facilities, longer length of stay patients, a lot easier to care for, and they have less staff because they can spread that staff over more and more patients, produces greater margin. Whereas programs I work with, large acute population, a lot more high acuity, a lot more diverse throughout the whole community. Yes, do they serve facilities? You bet, because that's actually part of the community, but they don't niche just at that. And they have a lot more people by the bedside. Now, I know some nonprofits have a lot of people by the bedside, and they're average, they're mediocre. They're not getting those visits in the last 7 days of life, and they should improve.
And I think Medicare is holding hospices across the country more accountable for exactly the measures you're talking about. They're looking at those, they're slicing and dicing, segmentating the hospice market in different ways to make sure that services are being adequately provided in each community.
And one more thing you and I bumped into in the past, that, the percentage of hospices that actually participate in the actual satisfaction surveys, we got to remember. I mean, just 2/3 don't, or 50%, whatever the number is, it's ridiculous, whatever.
Yeah, absolutely. Next, transparency through meaningful, accessible data. Evidence, not anecdotes, should drive decisions. Our second most read story, with over 6,100 reads this month, features the National Alliance for Care at Home's 2025 Facts and Figures Report, an indispensable annual resource that details patient characteristics, care settings, and levels of care, Medicare spending, provider profiles, and quality metrics. It draws on several sources. Hospice Analytics contributed to several of their charts and graphs with data, but a fantastic must-read report that just really summarizes hospice nationally. Again, it helps us figure out where an individual provider fits into the bigger picture of hospice and healthcare.
Yeah, and I just want props to you, the fact that you guys part. I could hear a lot of leaders, I don't have time to read the daily newsletter. I don't have time to read this facts and figures report. I'm sorry, guys. First off, this is why we do this podcast, is to pull out the things you should be focusing on. We got to get more sophisticated as we go forward. And yes, mission is beautiful, but if you can't back it up with data, it may be on us that we lose this incredible thing that we actually created that is called hospice today. And so whatever excuses you give, we got to get more sophisticated how we look at that data. What does it mean for your local market? Most importantly, what does it mean for how you're then leading your organization to focus on what matters most for the people by the bedside and challenging your organization to be the best version?
Absolutely. Ira's third pillar, driving competition based on quality, not volume. This shifts market dynamics towards outcomes that truly matter to patients and families. A heartening example, the HAP Foundation in Chicago released its Pediatric Resource Guide, a comprehensive collection of supports, financial, transportation, emotional, and more, for children with serious illness and their families. I just want to congratulate the HAP team for their work on this. It's a great resource that folks need to be aware of. Related, the Alliance is hosting an upcoming webinar series we're going to highlight in the newsletter soon on pediatric concurrent care, featuring experts Doctors Lisa Lindley and Megan Weaver, both fantastic colleagues and expert researchers and clinicians in this area. These resources highlight an underserved area where specialized knowledge can dramatically improve experiences.
This reminded me, and actually this is an organization, a for-profit that I coach. Unfortunately, now they've been sucked into a private equity-backed hospice, and I don't think they're doing this anymore. But they use pediatrics as a market differentiator for their whole hospice program. Now, to be honest with you, I thought that's cool, but I was always kind of skeptical of the implications until recently. Got involved in a very interesting payer conversation, and we're at the table with some amazing people on the payer side, one of which that grew up on the pediatric side. We were kind of doing the Vulcan mind meld between palliative care competencies and kind of their perspective. And I had this huge aha listening to this brilliant person about pediatrics. Pediatrics by nature looks at the patient and family as the true center of care. Like, think about it. You're not going to just look at the pediatric patient. You've got to look at the whole family support. And they were saying this is why they love hospice and palliative care, because that's so innate to who we are, and that's relates to a lot of other pediatrics. And it just spawned this incredibly innovative brainstorming of just some really cool best practice ideas from the pediatric side that I think we can improve, which then harkened me back to the theory of this one hospice that their pediatrics would actually elevate the clinical practice of their whole organization. So the fact that we've got, and I'm seeing more programs come back to pediatric, it is hard to make the model work financially. Not impossible. It can actually work. Maybe even more so compared to palliative care just in general, because of other funding that's out there for pediatric care. So just want to high five you for pointing that one out. And I think there's a whole frontier of pediatrics that could actually elevate, I love the term rising tide, raises all boats. Might be an interesting strategy. Not only is it the right thing to do from a mission standpoint, it may have implications you didn't even anticipate on your overall hospice palliative care quality care.
I would just echo that with a personal story that I hadn't thought about this until you were talking about it. But years ago, I had the opportunity to co-chair the University of Colorado Hospital Ethics Committee. And most of the ethics consults were end of life. They were geriatric end of life. So my interest in hospice and palliative care, fit very nicely into a lot of the discussions we were having. Well, my co-chair was a neonatologist, and she brought end of life perspectives from the beginning of life. And it really complemented the conversations and added breadth and depth to the services that we were providing for the geriatric end of life. And so in that same sense, what you're describing is those nuances and the care that gets provided for pediatrics can really enrich our geriatric services. Well said. Finally, and perhaps most powerfully, embracing and promoting our authentic brand, the compassion, dignity, and meaning at hospice's heart. These stories often travel farthest because they remind us of why we do this work. This month, Friends of Hospice in Oswego County, New York, in partnership with Hospice of Central New York in the Finger Lakes and Hospice of Jefferson County, launched its Life Longings Bucket List program. So I'll pause there to note, Friends of Hospice is not a hospice. They're working with hospices to do different programs, including this bucket list program. This particular initiative provides non-medical support to individuals facing life-limiting diagnoses, fulfill meaningful wishes, whether that's a special meal, a family gathering, or a simple comfort upgrade. This is what hospices do all the time. This helps us, I believe, reclaim hospice's original spirit, not just managing symptoms, but honoring lives and legacies. In this era of regulatory pressure and financial scrutiny, these kinds of initiatives counterbalance the data and dollars with the humanity behind why we do what we do. They build community trust and staff morale. Authentic branding isn't just marketing fluff. It's a strategic antidote to burnout and cynicism. How's your team, listeners, all listeners, how's your team incorporating similar life-affirming elements and getting back to that authentic brand of hospice?
That's a beautiful word. And I feel like, don't say anything, Chris. Don't screw that up, because that's the mic drop moment and the best way to end this podcast. But it does remind me of one of our stories. We had expanded our hospice into a market, a region that had not been well served. Death service ratios were less than 30%. And we started kind of what's their wishes kind of program. And beautiful story. This gentleman, he was a retired Baptist preacher. He had a vision of going on an RV trip with his family. And of course, he couldn't do that because he was terminally ill. But our team got together, got an RV, and he was able to go to an RV, just like a park, an RV park, locally. And his whole family joined him, and he baptized his grandson in the pool at the RV. And it just created memory. And actually, several years ago, bumped into one of the family members and shared just how impactful that was. It wasn't about the pain and symptom management we did. It was that life-affirming thing that now the family is carrying forward. And now that young man's following in his grandfather's footsteps, going to become a preacher himself. And it's just such a cool full circle moment. So high five that you pointed that out. Why I kind of keep my first category, but I find I'm flagging less and less that whole mission, life-affirming kind of section.
Well, and in that regard, I would encourage all our listeners that if you have similar stories, just write them up. Put them on, get permission, write them up, put them on your webpage, and send me a link to it so that we can run those stories in the newsletter and share them across the country, and hopefully get that flywheel spinning faster and faster, because I think there are some examples out there. It's a matter of if we know about them or not. Please help us draw our attention to those stories and those examples. It could be in your hospice, quarterly newsletter that you highlight a story and you put your newsletter on your webpage. Send me a link to it. We would love to include more of those stories.
Amen. Because that should be getting the headlines, not, oh my God, can you believe there are 100 hospices or a license in the same location suite on the same day? That's horrible, and it's painting all of us in a bad light. Whereas, we're so busy, we don't have time. Well, guys, it's kind of up to us. It's what we bring to the forefront. So thank you, Cordt. Cordt, this was fun. Any final words?
No, it's just thank you for taking time and allowing us to discuss these topics and share it with your listeners. And I think this is how we change the world.
Amen. Absolutely. So you and I, the next couple months, we've got Tom Kasumpis and Carol Fisher from MPHI joining us. After that, we got Joan Tino coming up. And then after that, it'll just be you and I again. And we'll keep kind of rolling this way. Each quarter, we'll bring some outside guests, again, using Dr. Bayak's framework. And then Cordt and I will look back over the quarter, keep pointing out top news stories of the month. So thank you again, Cordt. You and Joy keep doing the great work that you're doing. To our listeners, we appreciate you. At the end of each episode, we share a quote, a visual. We're going for a brain bookmark, like a brain tattoo. I'm looking forward to seeing this one for this show. It's going to be fun. Be sure to subscribe to our channel. We don't want you to miss an episode. Make sure you also tell your coworkers, your friends. This is one I'm going to kind of tag several people because there's so much good stuff in this. It's easy for us to rail against the world and be frustrated by things. Let's be the change we wish to see in the world. So thanks for listening to our podcast. And here's our brain bookmark to close today's show.
The people who are crazy enough to think they can change the world are the ones who do. By Steve Jobs. Thank you, USI, for sponsoring this podcast.